and thanks to the PFF for having me here to discuss a little bit on the ILD Pro registry, excuse me. So most of you think of clinical trials, you think of therapeutic trials. We're testing one compound or drug in a disease state or a number of disease states. But we also do, in the pharmaceutical industry, a lot of studies just learning about the disease, learning about patients, learning about what we can do to treat patients better. And I'm going to talk to you a little bit today about the ILD Pro registry. As Jennifer mentioned, I'm a senior clinical program lead at Boehringer Ingelheim, so I am involved in drug development. We have some nice early phase compounds that we're still studying. Some have not yet gone into humans, some are a little bit further along. I'm going to discuss today, though, something that is what we consider a low interventional study. It's not a true interventional trial in the therapeutic sense, but certainly an interventional trial as we try to learn about patients with interstitial lung diseases. This is a collaboration between Boehringer Ingelheim and the Duke Clinical Research Institute. And this registry was started in 2018, initiated in 2018, and the goal for the registry is to come up with 1,000 patients with progressive pulmonary fibrosis, non-IPF progressive pulmonary fibrosis, so we could learn a little bit more about these patients and what they experience and go through. There we go. The goals of the ILD Pro registry are to explore the clinical course of progressive pulmonary fibrosis. We talk in the medical community about lumpers and splitters, right? We lump everybody together who's got progressive pulmonary fibrosis, or we split them out into individual diseases that act in a similar way. And we're trying to understand what the right way is to think about patients with progressive pulmonary fibrosis. We're trying to determine the impact of PPF on patients. So you heard Dr. Karimi Shah this morning talk about patient-reported outcomes and understanding how the patients feel and function. So we want to understand what PPF does to people, to patients as they're experiencing it. We want to investigate some of the clinical and radiologic and blood-based biomarkers that are associated with disease progression. So hopefully one day we can predict who might get worse, so they're eligible for a trial, or who might respond to a therapy, so we know which drug to put you on. And hopefully in the future, there'll be many drugs to choose from. And then, of course, we want to understand how do physicians in the community treat patients with progressive pulmonary fibrosis, because there is no gold standard. There is no right way to do it, but we want to understand what are the options, so maybe one day we can come up with treatment algorithms that provide the best possible care to the right patients at the right time. There's over 40 enrolling centers for ILD Pro throughout the United States. And as I mentioned, the goal is to enroll 1,000 patients. As of 2018, we've enrolled about 700 patients so far. We're still enrolling. We did have a little downturn during COVID, as you might imagine. But no, those numbers are coming back up, and hopefully we'll be enrolling those 1,000 folks, and then we're going to follow them over time. What are the criteria to get into ILD Pro? You have to be older than 30. So the most important thing is that you can't have IPF. We have IPF Pro. We have an entire registry devoted to patients with idiopathic pulmonary fibrosis, trying to understand very similar things. But these are for patients with non-IPF ILD. And it has to be confirmed. They have to have some abnormality on their CT scan, what we call a reticular abnormality or traction bronchiectasis, so some abnormal thickening and widening of some of the airways in the end parts of the lung by the air spaces. And that has to be present either on a CAT scan or, if you're somebody who has had a biopsy in the past, on a biopsy. We're not doing any of these, we're not doing biopsies just to get people enrolled in the registry. And then you have to show us in the registry that you have already started to progress. For those of you who are familiar with progressive pulmonary fibrosis, there are some definitions that float around in the world. One of them is that your FVC, the number that we follow the most as clinicians, has decreased by greater than 10%. In some patients, perhaps your CAT scan is getting worse, or you're developing more symptoms over time, or some combination of the two. And we really want to see that combination of the two, because when we see those things, we know that the disease is progressing, and those are the people we really want to try to understand. At the time of enrollment, We tell you everything that's going on, and we call this, I mentioned, a low intervention study. It's a low intervention study because we do some interventions. For instance, we draw a little bit of blood. We ask you questions in the form of patient-reported outcome measures. But everything else we just collect based on what your doctor does for you. But at the time of enrollment, one of the first things we do is then we go back into your history. We go back into your medical records and we find out what's your diagnosis? When did you get your diagnosis? What medications are you on for your diagnosis? Importantly, with this particular trial, there's no contraindication. We won't say to you, hey, you can't be in our study because you're on this drug, or you have to be off that drug before you can get into our study. All we're doing is watching. And then about every 6 months, or as often as you see your physician, you get your measurements, we pull those measurements. Every 6 months, somebody from the call center at Duke will call you and say, hey, how you doing? Just checking in, make sure we have all the information we need, that we've collected everything, and we follow you over time. And the goal here, of course, is to learn about how the patients with progressive pulmonary fibrosis act, and by patients act, I mean how the disease acts in patients with PPF. So I just want to show you 2 slides worth of data on the first almost 500 patients enrolled in the study. So even though we're following people longitudinally and we want to get that 1,000th person, and we want to get that 1,000th person out for 5 years so we can see over time how everybody does, we do take data cuts on occasion, just to make sure that we are collecting the data we say we're collecting, and to start to try and come up with some understanding. So what you can see here is almost or over half of the patients are female. As you might expect with non-idiopathic pulmonary fibrosis, many of the diseases that fall into that category are female predominant, specifically the connective tissue diseases. 75% of the population is white. Almost half have a smoking history, not surprising. And by pulmonary function standards, these patients have moderately severe disease, so an FVC around 60% and a DLCO around 40%. So these are not people who are newly diagnosed necessarily, or if they are, the disease has been going on for quite some time. If we look at the breakdown of the diagnoses that fall within our PPF diagnosis, almost half of them are autoimmune-related interstitial lung diseases. So scleroderma, lupus, rheumatoid arthritis, myositis, the list goes on and on. These autoimmune disease-related interstitial lung diseases. The next highest group are folks with hypersensitivity pneumonitis, nonspecific interstitial pneumonitis, IPAF or interstitial pneumonitis with autoimmune features, and then this bucket of unclassifiable, which doesn't mean that it's not one of those other disorders. It's that we can't figure out what it is exactly. So even though we've tried, we can't give it a name. It's unclassifiable. If we look at the patients in the ILD Pro registry, you can see medication-wise, the large majority of them are on immunosuppressant medications. Again, not surprising, almost half are connective tissue disease or autoimmune disease patients, so they're going to be on immunosuppressants or cytotoxic agents. Interestingly enough, over half are also on PPIs, given the interest and concern about reflux disease in patients with interstitial lung diseases and idiopathic pulmonary fibrosis. Many of these patients are on proton pump inhibitors. And you can see on down the line, oral corticosteroids, again, not surprising. Bronchodilators, a little bit surprising, although I know that many patients in here and many patients in my own practice when I was practicing come to us in the interstitial lung disease clinic having first been diagnosed with some airway disease. So not necessarily surprising that some of them are still on bronchodilators. Statins, reflecting perhaps the prevalence of hypercholesterolemia just out in the public, and then much lower numbers of folks on ACE inhibitors or ARBs, nintedanib, pirfenidone, anticoagulants, and so on down the line. That's all I want to tell you about now, because that's all I know right now, because we need more patients now. So we are open. It is enrolling now. Many of the PF Care Center Network sites are co-investigating sites of the ILD Pro registry. If you have interstitial lung disease, your physician has told you you have progressive pulmonary fibrosis, and you are interested in helping us understand more about this disease condition so that we can develop drugs for the next generation, it would be most helpful and most appreciated. So I am going to stop now.
Thanks to the PFF both for putting on this wonderful meeting, but also giving me the chance to just talk about this trial. So I'm representing today the Scleroderma Research Foundation, and I'm going to talk to you about the Conquest platform clinical study for scleroderma. So for those of you in the audience who don't know, scleroderma is an autoimmune disease that leads to problems with many organs in the body. It's typically characterized by thickening and fibrosis of the skin, but about 2/3 of the people with the condition also have interstitial lung disease and pulmonary fibrosis. And in fact, interstitial lung disease is the commonest cause of death in people with scleroderma. And the Scleroderma Research Foundation is a patient-based foundation whose goal is to improve treatments for patients with scleroderma by driving research. And so to do this, they've partnered with a number of groups to try and develop a clinical trial program that will make it easier to run trials in patients with scleroderma-associated interstitial lung disease. And hopefully some of what we learn from running these trials will actually help us in treating other forms of interstitial lung disease as well. And something that perhaps doesn't get thought about when we talk about running clinical trials is how challenging it is from an administrative and bureaucratic perspective to start a clinical trial. So when you start a clinical trial, you put a lot of work into writing a protocol, which is the set of instructions by which the trial is conducted. And then an enormous amount of work goes into identifying centers, so hospitals, academic institutions that can deliver the trial. And there is a lot of contracting and paperwork that has to go on between the sponsor of a trial and the clinical trial centers. And in my experience, having now been in the US for 3 years, the US takes bureaucracy to a new level. I thought things were bad in the United Kingdom, but they are worse here. I apologize, but they are. And so when a company comes to me at USC and wants to start up a trial, I know it's going to take at least 6 to 8 months to get through the paperwork and the contracting. And the company that's running the trial has to do that not just with USC, but another 20, 50, 100 sites in the US. And it's an incredibly onerous business. And so what we've done with the Scleroderma Research Foundation is set up a so-called platform trial. And the concept of a platform trial is that you have a single master protocol, that you sign up each center, and then you run a series of trials, either together or back to back. And by doing that, you save a lot of time and effort and energy on the contracting process, because you sign one contract for which you can run multiple trials into the future. You need a single set of IRB approvals, so you only go once to the IRB to get approval for the overall protocol, and then you simply have to update the IRB as you add in new treatments into the trial. And so the goal of this is that it saves a lot of time in delivering clinical trials, both for the centers themselves, but also for the sponsors who put drugs through this platform. And so the rationale for Conquest is here on the slide. We want to develop new treatments for scleroderma ILD. We want to speed up the delivery of new trials for patients with scleroderma ILD. It's a rare disease. These are difficult trials to run. They require multiple centers. And as I've told you, we want to take this novel approach of using a single platform upon which we can test multiple drug compounds in the future. And this being an ILD trial, the goal is to test compounds primarily to see if they have a positive effect on the interstitial lung disease. And in doing that, we're designing a trial that is very similar to other trials run in people with interstitial lung disease. We're using forced vital capacity as the primary endpoint. We are looking for change in forced vital capacity over 52 weeks. But as our secondary endpoints, we're also looking at other measures. Some of these are specific to scleroderma. And so I've already told you about the skin being one of the main organs affected in people with scleroderma. So we're looking at changes in skin thickness. We're looking at changes in something called the CRIS score, which is a score that measures fibrosis in all the organs in the body, not just the lungs, but the skin, the heart, and elsewhere. And we're looking at some quality of life measures as well. And obviously, we want to study safety and tolerability. And part of what we want to do with this trial is also learn how to do trials better in the future. So we will be collecting things like blood samples to do biomarker discovery in a way similar to Eric's description of ILD Pro. And we'll also be collecting imaging data. And our hope is that as the trial moves forward into the future, what we learn from the first 2 or 3 drugs to be put through it, we will be able to apply to future iterations of the study and make it sort of faster and even more dynamic as time goes on. It will be a global study, so although the SRF is a US-based organization, we are looking to leverage centers around the world. It's going to be an ambitious project with more than 130 different sites. All of these sites will have expertise in ILD, but also we will involve rheumatologists with experience in treating patients with scleroderma. We hope for each drug that's involved, we are going to recruit 100 patients on active treatment. We're going to recruit 100 patients on placebo. As we start the study, we're going to start with 2 drugs in parallel, and those drugs are going to be able to share the placebo group. So the other benefit of this platform design is that not only do we hopefully shorten the time between each trial, but by overlapping trials, we can use the same placebo patients across both treatment arms. And that has the advantage that patients have got a 2/3 chance of having active treatment rather than a 50% chance. It also means we only need to recruit 300 patients for the 2 drugs instead of 400 that we would have had to do if we'd done traditional studies side by side without this platform design. And this here just provides a schematic of how we're going to do it. You'll have therapy A and therapy B, and in the future, if we become more ambitious, we could also have therapy C, so you make it even more efficient in terms of the number of placebo patients required. Patients will be randomized into one arm or the other, and then they'll be randomized onto active treatment or placebo. And as I've told you, the primary endpoint will be after 52 weeks and will be change in FVC. I'm not going to go into all of this in enormous detail. If there is anyone in the room who thinks they might be a candidate for this trial, I'm very happy for you to contact me. The PFF have my email, if nothing else, and people can email me. And I can put people in touch with their nearest center. Broadly speaking, I'm not going to go into this in enormous detail. Obviously, as with other trials, we have inclusion and exclusion criteria. One of the things that we are trying to do with this study is to enrich it for patients with more progressive disease. One of the challenges, again, of doing clinical trials is that you want to be giving treatment to patients whose disease is getting worse, because what we're trying to do is halt disease progression. We're not, in truth, expecting to see improvement. So we need patients with progressive disease rather than patients who are already stable and doing well on therapy. And so we've included criteria that try and enrich for patients with progressive disease. And again, Eric, in his talk for ILD Pro, outlined some of those. So we're looking at evidence of previous physiological decline, loss of FVC or DLCO in the previous year or 2. We're also looking at things that are very specific for scleroderma, like increased levels of inflammatory markers, evidence of active disease with either a recent change in skin thickening or active arthritis. And there will be central evaluation of CT scans. We're looking for patients to have more than 10% of their lung involved by ILD, again, because we believe that's a marker for individuals more likely to have disease progression. And then, as with other ILD studies, we have some physiological criteria. Again, we want to avoid people having extremely severe disease, but otherwise we're trying to include as many people as possible in this study. And the other point on there is we're also allowing certain background treatments. So we're allowing people to be on background mycophenolate or methotrexate as part of the treatment for their underlying autoimmune disease. We do have exclusion criteria. I'm, again, not going to go through these in detail. They're fairly standard and similar to most other clinical trials in this disease area. And so this is my final slide, which is our timeline. So we've essentially built the study. We have the protocol. We have found 2 pharmaceutical partners who are contributing their drugs to the trial platform. So we're in a position now where we are anticipating that we're going to recruit our first patient towards the end of Q1 next year, so hopefully around March time, 2024. We've started the process of identifying sites and the joyous process of writing contracts. If everything goes to plan, we hope to recruit those first 2 trials within 18 months, so have a readout essentially 36 months from March next year. And at the same time, for anyone that's representing a pharmaceutical company in the room, we will be looking for new partners who will be able to put their drugs into the platform as we roll out the first 2 drugs to go into it. So I'll stop there. Thank you very much.
So good afternoon. I have to say it's quite exciting to be back at the summit and for it to be in person. It is a challenging event to have a Zoom meetings for 2 years, and it's really wonderful just to begin to interact and talk with individuals. As Jennifer said, my name is Greg Cosgrove, and I represent Pliant Therapeutics. And I'd like to talk to you today about bexotegrast and our late-stage development program for the treatment of IPF. Just to underscore that bexotegrast is currently under development, so the comments I make are in regards to it. It's not an approved therapy, but it's an investigational product. So who is Pliant? Some of you may or may not know of us, but we're a clinical stage biotech company of over 150 individuals that are dedicated to one real vision, and it's an aspirational one, to develop therapies which target the underlying biology of fibrosis with a vision to transform the lives of patients with those therapies. In today's presentation, I'd like to touch base on the mechanism of action of bexotegrast, or the proposed mechanism of action. And then we recently completed a phase 2A safety study called INTEGRIS-IPF, and I'll review some of those data. And lastly, introduce you to BEACON-IPF, which is our phase 2B study of bexotegrast. So one of the important proteins that's expressed in almost all fibrotic diseases is transforming growth factor beta, or TGF-beta. It's essential for normal health and development. But in the setting of injury, whether it be in the lung or liver or kidney, TGF-beta is overexpressed, and it's considered the master regulator of fibrosis by many. The science behind bexotegrast was developed when investigators identified that 2 proteins in the lung are upregulated in the setting of injury and release TGF-beta from its natural stores within the lung at a level that exceeds the natural normal development in the lung, and it's excessive, so it promotes fibrosis. Those 2 proteins are alpha V beta 1, which is expressed in the fibroblasts that make scar tissue, and alpha V beta 6, the epithelium that line the air sacs of your lung. So both increase the availability of that TGF-beta and then promote fibrosis. Bexotegrast is an oral once daily pill that blocks alpha V beta 1 and alpha V beta 6 selectively, and by doing so decreases TGF beta within the lung. But since those proteins are predominantly expressed in the lung, it doesn't necessarily affect TGF beta throughout the rest of the body, or affects it minimally, allowing for decreased expression in the lung, but minimal impairment in the rest of the body. So with that background on bexotegrast, the original study, Integris IPF, was a safety study designed to assess safety over 24 and then subsequently at least 24 weeks in the last cohort. We enrolled individuals, and it was a 3-to-1 randomization, so patients had placebo and then different doses of bexotegrast, 40, 80, 160, and 320 milligrams. We evaluated that safety profile over 12 weeks, but also had exploratory analyses where change in FVC, which is the registrational endpoint. We looked at a change in radiographic fibrosis, or QLF, and then we assessed cough at the beginning and at the end of that 12-week time period. And we, as Eric and Toby had mentioned, assessed biomarkers that are in development and investigation that tie into the change in fibrosis. So a summary of those data, and these have been presented at the American Thoracic Society and then also at ERS recently, suggested, importantly in this safety study, that bexotegrast had a favorable safety profile and it was well tolerated over that 12-week time period. And that's characterized by most of the adverse events were mild to moderate in nature, and for serious adverse events, none were attributed to bexotegrast, but attributed to the underlying disease itself, IPF. What we identified, and is exemplified on the top up leftward panel, is we saw a reduced decline in FVC in that 12-week time period for individuals on bexotegrast, in contrast to those that were receiving placebo. And as occurs in almost all studies in IPF, individuals were on either pirfenidone or nintedanib, and about 20% were not on either of those therapies. So we could see the effect on top of and begin to investigate the effect of bexotegrast independent of those approved therapies. So what we see in the panel on the left is that there was a separation of the curve such that at each time point, at least here in the 320 milligram cohort, we saw a statistically significant difference between the FVC at week 4, week 8, and at week 12 in those on bexotegrast, in contrast to the placebo cohort. And that was further supported based on the change in radiographic fibrosis, where those individuals, and this is specific for the dose, we saw a dose-dependent decrease in the progression of fibrosis based on their HRCT scan, where there was minimal or no change at the higher doses of 160 and 320 milligrams, in contrast to those who were on placebo with or without nintedanib or pirfenidone. To further support these data, we saw changes in the biomarkers that link to the change in fibrosis in the lung. So these data were important as we move our program forward. And during the study, before the 320 milligram cohort was initiated, we elected to continue the evaluation out to at least 24 weeks and up to 48 weeks in that last cohort, the 320 milligram group. So we had interim analysis at 12 weeks, and then we had the same analyses, safety as well as change in FVC, out to 24 weeks. The safety ended up going out to 40 weeks for a certain number of individuals. What we identified with that additional time period is the safety profile continued to remain favorable out to that 24 and then 40-week time point, with the majority of adverse events being related to the underlying disease. The most common adverse event that was identified was diarrhea, but occurred almost exclusively in individuals who were on pirfenidone or nintedanib, with the exception of one individual who had underlying ulcerative colitis, a disease that causes diarrhea. So the question we asked, well, the changes that we saw at 12-week, do they persist at that 24-week time point? And what we saw is that individuals that had that improvement in FVC at 12 weeks in the bexotegrast group continued to have that improvement at 24 weeks. In contrast, individuals that were on the placebo with or without nintedanib, if they had that improvement in FVC at 12 weeks, it did not remain, and all were below their baseline values at the 24-week time period. Similarly, we assessed radiographic fibrosis, and a similar phenomenon occurred, that there was minimal progression based on that 2%, which is the important change in QLF in the bexotegrast group, where at 12 and at 24 weeks, they did not exceed that progression, in contrast to the placebo group that at 12 and 24 weeks, they had progression of their disease based on radiographic assessments of fibrosis. And we categorized them in terms of how many patients had stabilization or improvement in fibrosis, and you see that in the bexotegrast group, that was approximately 71%, in contrast to those on the placebo cohort, where it was only a third. So these data truly support the ongoing development of bexotegrast based on its favorable safety profile, the fact that it was well tolerated, and this is evidence based on the safety assessments, the fact that individuals did not discontinue after that 12-week time point up to week 40 due to an adverse event. There were no drug-related or bexotegrast-related serious adverse events. And the data support that there was a treatment effect not only at 12 weeks, but out and persisted at 24 weeks, supported by changes in QLF. Now, this was a safety study, and we had those exploratory analyses, and so there are limitations in terms of the duration of evaluation and the sample size, but they support our ongoing evaluation moving forward, and that is the Beacon IPF study, which is now enrolling. You can come and talk to us at the booth. You can visit the website, www.beaconipf.com, but this is a 52-week study, phase 2B assessment, and we're going to compare the changes in FVC at week baseline to week 52 at 160 milligrams, the 320 milligram group, compared to placebo. Patients can be on either of the two approved therapies, or if they choose not to, they can participate just as well. We'll assess that change in FVC. We'll look for disease progression, as Eric and Toby have mentioned. We'll also look at the group of individuals that are not on background therapy and assess the treatment effect of bexotegrast on top of or independent of those two approved therapies. And then, as we've heard today, importantly, what changes in a patient's life during that year? How do they feel? What can they do during the day differently compared to when they first started the study? And as always, we'll identify any ongoing safety events to compare that to placebo. So this will truly allow us to better assess bexotegrast and move the trial forward. What can patients expect if they choose to participate? It's a 52-week study with a screening evaluation. We've tried to limit the number of study visits so that we acquire the necessary information, but also be respectful of your time and the visits that can become cumbersome. So there are 8 study visits, and there are standard evaluations. And also, we know many patients travel from quite a distance to participate in studies, so we do offer the ability to reimbursement for travel and their time during that study visit. So we want to make it a patient-friendly opportunity because you're volunteering to help us understand and further identify treatments for idiopathic pulmonary fibrosis moving forward. So I'll stop there, and certainly if you have additional questions, I'll be around. My colleagues from Pliant are there at the booth. You can go to the website, and you can also scan the QR code, and it'll take you directly there. So thank you very much.
Hi, I'm Rachel Warren. I am a program manager for familial pulmonary fibrosis research at the University of Colorado. And I'm going to talk to you a little bit today about how to get involved in familial pulmonary fibrosis research studies that we have going on at the University of Colorado. So first, I'll just talk a little bit about what we know about the genetics of pulmonary fibrosis. So we know that approximately 20 to 30% of people with pulmonary fibrosis have a family history of pulmonary fibrosis. And there have been some genes that have been discovered in some of these families with IPF. Some of them are common variants you may have heard of, like MUC5B. There are also rare variants like the telomerase variants and those that have to do with the surfactant proteins. And these variants have also been observed in sporadic IPF as well, or families that just have one case. But genetics alone don't account for disease development. Genetics predispose to disease. They can increase the risk for getting the disease if it runs in your family. But there are likely other factors that contribute to disease development. Some of them may be aging, smoking history, infections, or other environmental exposures. And we also know that certain genetic variants are associated with different clinical outcomes. So some are associated with increase in disease progression. Others are associated with other medical conditions like bone marrow disorders, emphysema, or some cancers. And then there are others that are associated with different clinical features. Some families experience an earlier age of diagnosis, early graying of the hair, different CT scan patterns, and other things. And you can also have different types of pulmonary fibrosis within the same families. So the first study that I'm going to talk about is our genetics of pulmonary fibrosis study. This is a registry study that's been going on for the last almost 30 years. And we have been enrolling families that have at least 2 cases or more of pulmonary fibrosis in their family, with at least one of those cases being IPF. We enroll adults, so anybody 18 and older is eligible for this study. And we enroll folks that have the disease as well as their unaffected family members. And the study procedures are pretty simple. It's a paperwork packet that we send in the mail that includes a consent form, a release of information form, and a health questionnaire so that we get to know a little bit about each individual that participates in our study. And then it's also a one-time blood draw. Something to note is that no travel to Denver is required. You don't have to come see me in person. We do all of our study coordination over the phone and through the mail. So we mail you all of the materials that you need, and we pay for the blood draws as well. What I'm going to spend most of my time talking about is actually a research opportunity for unaffected family members. It's called the APPLE study. It stands for the Advancing Prevention of Pulmonary Fibrosis. We're sponsored by the PFF as well as the NIH, specifically the National Heart, Lung, and Blood Institute, NHLBI. And the goal of the APPLE study is to enroll 1,000 individuals that we consider to be at risk from families with 2 or more cases of pulmonary fibrosis. And what we'd like to do is study this population of individuals who, to determine who has early signs of pulmonary fibrosis and who does not, further define the genetic profile, really delve into understanding more of the environment, and follow them over time. So it is a longitudinal 4-year study to look at progression, to see who's progressing into early stages of disease and who isn't, and then also identify other risk factors for disease development and progression. So who can participate? If you come from a family with 2 or more cases of pulmonary fibrosis, and at least one of those cases is IPF, and you have not been diagnosed with an ILD by a physician, and you're between the ages of 40 and 75, and are willing to complete the study questionnaires and procedures, we'd love to talk to you about enrolling in the APPLE study. Some other things to note is that multiple family members are welcome to participate. There may be several people that fit this criteria in your family. We don't cap it. So if there are multiple family members that would like to participate, they are welcome to do so. And again, you don't need to live near Denver to participate. 90% of our cohort actually live in a state that is not Colorado. Again, we do most of our study coordination over the phone and through the mail. So our study protocol includes several things. The first is that it's questionnaire-based, and so during the baseline year of the study, or the first year, year one, we ask about job history, smoking history, potential environmental exposure, general health questions, just to get an overall picture of the life that everybody lives in the study. We also do a physiological assessment on each of our participants that includes a high-resolution CT scan of the chest and pulmonary function testing, or PFTs. And we set those up local to each participant. We try to do our best to get within 30 minutes of where each participant lives across the country. We do our best. And the nice thing about it is while you're having it for research purposes, you now have a baseline for how your lungs are functioning and what they look like on a CT scan. And regardless of what the result is from those tests, you have access to them so that you can share them with your primary care team. We also collect blood samples and other biological specimens as well. That's how we do a lot of the genetic work that we do. We are a genetic study at our core. And we try to do this all in our baseline year of the study. And then the next 3 years are follow-up. So our recruitment so far, we have just about 600 participants. We're looking for about 1,000. We've set up over 300 CTs and pulmonary function tests so far. And as you can see from the map, it's not just Colorado. We've got people across the country. So if you look at your state and you see it's underrepresented and you are interested and eligible, let us know. We'd love to, have you rep your state. So how does the follow-up work? So all of our subjects are contacted every year, once a year for that 4 years. And so for the 3 follow-up years, we send you a follow-up questionnaire to assess if there's been any changes, specifically anything that's changed in your environment, any environmental risk factors that you may be exposed to, or if you've had any clinically significant outcomes, if you've had a diagnosis of an ILD, or if there's been a change in vital status. And then the other thing that we're doing as part of the way that we're measuring progression is we're asking some of our subjects to return in a case cohort group to repeat all of the questionnaires and repeat the biological sampling, the CT scan, and the PFT so that we can look and see what's changed after 2 years as we're following folks along. And again, this is just to look at the phenotypic heterogeneity and the progression of preclinical pulmonary fibrosis. So this is my contact information up here. We also are exhibiting at the PFF Summit this weekend, so you can find us at the booth in the exhibit hall. I also have Dr. Joyce Lee's information. She's one of the investigators on this study. We're both open to questions, happy to speak to anybody who's potentially interested in joining us on this project and this journey for the next 4 years. And thank you so much for your time.